Hello, and welcome to the Chest Journal's Editor Highlights podcast. Each month, Chest Editor-in-Chief Dr. Peter Mazzone highlights key articles from the current issue of the journal to help clinicians stay informed about new research in the fields of pulmonary, critical care, and sleep medicine. To introduce this month's episode, here is Dr. Peter Mazzone.
Thank you for tuning in to the Editor's Highlight podcast for the February 2026 issue of the journal Chest. We have a great lineup of diverse content in this month's issue. Over the next 15 minutes or so, I'll provide a brief overview of key manuscripts published in each of our content areas. In our asthma section this month, you will find an American College of Chest Physician clinical practice guideline on treatment of severe asthma in adults with asthma biologics. Our chest infections content area is next. The impact of culture conversion during treatment of Mycobacterium abscessus complex pulmonary disease on survival has not been explored. In this issue, Joe and colleagues report findings from a retrospective study of 172 patients with Mycobacterium abscessus complex pulmonary disease who completed at least 6 months of macrolide-based treatment in South Korea. The study was designed to determine if culture conversion was associated with mortality. 58.1% of those included achieved culture conversion at treatment completion. The all-cause mortality rate, 5- and 10-year mortality rates, were higher in those without culture conversion. For example, 10-year mortality rates were 51% versus 7.7%. A 1.57-fold increased mortality risk was identified in those without culture conversion. These findings identify culture conversion at treatment completion as a key prognostic factor in patients with Mycobacterium abscessus complex pulmonary disease. Completing this section is a special features review on intrapleural fibrinolytic therapy. Our COPD section is next. A new multidimensional diagnostic schema has been proposed to diagnose COPD. Evidence supporting this approach in Chinese individuals and those who never smoked is limited. In this issue, Wu and colleagues report findings from a 3-year prospective multicenter community-based cohort study designed to determine if the new multidimensional diagnostic approach to COPD is practical in the Chinese population and in those who never smoked. The multidimensional criteria included either an FEV1 to FVC ratio of less than 0.7 and 1 minor criteria, or at least 3 minor criteria. Minor criteria included emphysema or bronchial wall thickening on imaging, dyspnea, poor quality of life, and chronic bronchitis. Among those without airflow obstruction, 4.8% met the multidimensional criteria, while 5.8% with airflow obstruction did not meet the criteria. Those with airflow obstruction who were excluded had an exacerbation risk and rate of lung function decline similar to those without COPD, while those without airflow obstruction who met the criteria had a higher risk of exacerbations compared to those without COPD. Results were similar in those who never smoked. These findings suggest the new multidimensional diagnostic criteria for COPD can exclude those with a favorable prognosis and identify those at higher risk for exacerbation in the Chinese population and in those who never smoked. Completing this section is a research letter that reports a comprehensive clinical trial landscape analysis of targeting Th2 cytokines and alarmins in COPD therapy. Next is our critical care content area. During the COVID-19 pandemic, patients transferred between ICUs in France had a lower ICU case fatality. It is unclear if this difference was related to the selection of healthier patients for transfer. In this issue, Grimaud and colleagues report findings from a multicenter retrospective cohort study of 285 transferred and 667 control patients. The study was designed to determine if the 28-day ICU case fatality rate of transferred patients was different than that of matched control patients. At ICU admission, age, COVID-19 severity, comorbidities, and the simplified acute physiology score 2 were similar, while those transferred weighed less and were more autonomous than the matched control patients. Case fatality was 7-fold lower in the transferred patients. The ICU stay was longer. Delirium, psychiatric disorders, and neuromuscular blockade exposure were more frequent in the transferred patients. Acute kidney injury was more frequent in the control patients. These findings suggest that the selection of healthier patients for transfer may have contributed to better survival, but this could not explain all of the benefit of transfer from an overcrowded care environment. Also in this section is a research letter describing a feasibility study of exertional hemodynamics in critical care cardiology and a chest narrative review on emerging technology for non-invasively measuring oxygen saturation. On to our diffuse lung disease section. The optimal treatment strategy for rheumatoid arthritis-related interstitial lung disease remains uncertain. In this issue, Wu and colleagues report findings from a target trial emulation study that used data from the TriNetX US Collaborative Network database designed to determine if treating patients with rheumatoid arthritis-related interstitial lung disease with tocilizumab results in a different prognosis than treatment with rituximab. Each matched cohort included 1,194 patients. All-cause mortality did not differ between the treatment groups. Patients with rheumatoid arthritis-related interstitial lung disease with elevated baseline inflammatory markers experienced higher risks for mechanical ventilation, the hazard ratio of 1.94, and all-cause mortality with a hazard ratio of 1.40 in the tocilizumab treatment group. Those naive to tumor necrosis factor inhibitor therapy with high inflammatory markers had an increased risk of mechanical ventilation with a hazard ratio of 1.54. These findings suggest comparable effectiveness and safety of tocilizumab and rituximab in rheumatoid arthritis-related interstitial lung disease overall, with rituximab leading to improved outcomes in those with elevated baseline inflammatory markers. Also in this section is a prospective multi-center study designed to develop and validate a multimodal-based machine learning model for the diagnosis of usual interstitial pneumonitis, and a How I Do It review of whole lung lavage in pulmonary alveolar proteinosis. Next is our education and clinical practice content area. The clinical utility of the diffusing capacity for carbon monoxide is limited by measurement variability. In this issue, Yadav and colleagues report findings from a cohort study of 5,069 patients with stable spirometry and at least 2 hemoglobin-adjusted diffusing capacity measurements, designed to determine the magnitude and determinants of DLCO intersession variability. The DLCO variability was high, with 90th percentile values of 3.5 mils per minute per millimeter mercury, absolute, 15% for percent predicted, and 21% for relative percent. Higher baseline diffusing capacity, lower hemoglobin, male sex, and restrictive patterns on spirometry were associated with greater absolute variability, but they only explained a fraction of the observed variability. measurement variability increased systematically with DLCO magnitude. A 3-tier grading system was developed based on the 85th and 95th percentile thresholds, with the 3 tiers being stable, possible change, and definite change. Also, a hybrid approach using baseline diffusing capacity specific absolute thresholds was developed. These findings identify substantial intersession variability of DLCO measurements and discover potential tools for distinguishing clinically significant diffusing capacity changes from normal measurement variability. Also in this section is an original research article on the assessment of breathlessness during incremental cardiopulmonary exercise testing and how I do it review on in situ cardiac arrest simulation. Our pulmonary vascular content area is next. Balloon pulmonary angioplasty can effectively treat chronic thromboembolic pulmonary hypertension. It is unclear if left ventricular dysfunction influences the effectiveness and safety of balloon pulmonary angioplasty treatment. In this issue, Sved and colleagues report findings from a retrospective analysis of 170 patients with chronic thromboembolic pulmonary hypertension treated with balloon pulmonary angioplasty. The study was designed to determine if elevated pulmonary artery wedge pressures impact the effectiveness and safety of balloon pulmonary angioplasty in patients with chronic thromboembolic pulmonary hypertension. Elevated pulmonary artery wedge pressure was present in 13.5% of the patients. Those with an elevated pulmonary artery wedge pressure were older, had a higher BMI, higher baseline troponin levels, and a greater burden of comorbidities. After treatment, those with elevated pulmonary artery wedge pressures had a smaller reduction in mean pulmonary artery pressure and lower improvement in pulmonary arterial compliance and 6-minute walk distance. No differences in overall survival and adverse event rates were noted. These findings suggest that an elevated pulmonary artery wedge pressure is associated with reduced hemodynamic and functional benefits from balloon pulmonary angioplasty in people with chronic thromboembolic pulmonary hypertension, but procedural safety and long-term survival support balloon pulmonary angioplasty as a viable option in this subgroup. Completing this section is a research letter that explores the pulmonary resistance-compliance relationship. Next is our sleep medicine content area. Treatment of obesity hypoventilation syndrome with drugs that activate upper airway muscles and stimulate breathing are being explored. In this issue, Perger and colleagues report findings from a randomized double-masked crossover trial in 15 patients with obesity hypoventilation syndrome. The study was designed to determine if 2 weeks of 500 milligrams of acetazolamide plus 100 milligrams of atomoxetine daily effectively reduces the mean nocturnal carbon dioxide level. The study group had a median BMI of 44 kilograms per meter squared, baseline median transcutaneous CO2 levels of 49 millimeters of mercury, and a median apnea-hypopnea index of 64 events per hour. Treatment decreased nocturnal transcutaneous carbon dioxide levels by a mean of 5.8 millimeters of mercury, as well as diurnal carbon dioxide. Median apnea-hypopnea index decreased by 20.9 events per hour, and mean overnight oxygen saturation increased by 4.3%. This proof of concept study showed that treatment of obesity hypoventilation syndrome with acetazolamide plus atomoxetine can significantly improve sleep-related hypoventilation, oxygen saturation, and apnea-hypopnea index, encouraging further study. Completing this section is an original research study that evaluates the relationship between Framingham 10-year cardiovascular disease risk score and pulse wave amplitude drop characteristics in a sleep clinic cohort. Next is our thoracic oncology content area. Many patients are unaware of the need to repeat lung cancer screening annually despite shared decision-making. In this issue, Wornley and colleagues report findings from a controlled trial of a health communication intervention that included print plus video material delivered through the electronic health record patient portal, designed to determine if additional health communication improves patient knowledge of lung cancer screening timelines. The intervention increased the proportion of people with normal lung cancer screening exams who knew they needed to return in 1 year from 62% to 83.9%, a relative risk of 1.35 in first-time screeners. The intervention did not lead to a difference in those screened 2 or more times. Both tobacco-related stigma and self-efficacy were high and were unchanged by the intervention. These findings show that a multi-format communication intervention can help to improve short-term knowledge of lung cancer screening timelines to return, with the potential to improve adherence to annual screening. Also in this section is a SEER Medicare-based analysis of procedure patterns and survival in advanced non-small cell lung cancer with malignant airway obstruction, and a research letter that describes the clinical and research implications of nonspecific necrosis on peripheral pulmonary lesion biopsies. I encourage you to read our commentary series, where you'll find a discussion on reducing inhaler waste and costs through sustainable interventions, as well as 2 pieces from our Statistics for Clinician Scientists series, as well as our Humanities series, where you'll find an original research article on post-intensive care syndrome awareness and communication, as well as an exhalations piece titled Let's Play a Game. Finally, please review our case series publications for the month, which provide novel and educational cases to help improve your clinical skills. I hope you enjoy reading all of the high-quality content available in this month's issue of Chest. As always, I'm grateful to the authors of this work, the reviewers who volunteered their time to improve the quality of these manuscripts, and to our editorial board for guiding everything that we do. Until next month, I hope that you enjoy the February issue.
Thanks for listening to the Chest Journal's Editor Highlights podcast. You can find the articles mentioned in this podcast and more on chestjournal.org. And if you're looking for more context and commentary on articles in the current issue, please check out the original Chest Journal podcast, which features in-depth discussions with the authors themselves. We'll be back again with more Editor's Highlights next month.